First of all, let me paint a little bit of a painful scenario, but not hopeless. Physician-assisted suicide and euthanasia are on a fast track to being decriminalized or legalized. Abortion, the panacea for random sexuality, really roars right on. If I can give you an example, just in a small rural area of West Florida, we had a report, what we call the Healthy Start Coalition, last week, and it indicated that total births were about 4,460. The number of abortions were over 5,000. That's, I think, a very sort of a microcosm of what's going on in our society at the present time. As you know, we have an area that has quite a notoriety as far as the abortion issue, and you can imagine in a conservative area, if that's the rate of abortion, what it is in our nation as a whole. Other parts of the scenario, the physicians and managed care organizations are really agents representing third parties first and the patient second. Healthcare is a commodity market where medical technique and technology, along with the consumer's desires, are really dominant. The character of medical practice, lacking an ethical consensus, redefines humanity and marginalizes vulnerable, burdensome segments of our society. And essentially, a new utilitarian death ethic is emerging that now promotes the concept of prescribing death. The key to ethical medical practices has already been talked about. Still remains a physician-patient relationship. Our profession of medicine is not squarely facing the issue of the new medicine, as Dr. Cameron so eloquently put it, or the new ethic and its impact on that particular relationship, physician-patient. We have an ethic that accepts the notion there is no right way, where individual choice and the decision-making process creates myriad confusing options. The idea of individual autonomy becomes the only agreement, and informed consent the key in a pluralistic medical culture. Pluralism and patient autonomy engender a contractual rather than a covenantal relationship where all values are negotiable. The old paradigm, with its fundamental concept of medicine as a covenant and a duty to heal in the context of the sanctity of the life of the patient, is being replaced. A new paradigm of the quality of life of the patient and relief of suffering, which may include killing, seeks to replace the old one. Medicine indeed is in a crisis. Its future is somewhat grim because we've fractured the ethical framework whose crucial values are divorced from clinical practice. The adjusting and the changing ethics of medicine, exemplified by abortion, suicide, and euthanasia, represent the emerging death ethic. And this is based on a changing value of human life and heralds the threat of institutionalized killing. We talked about niche last night. Can the medical profession survive with just any set of values regarding human life? The primary purposes of healthcare reform is to control costs while providing universal coverage. That automatically assumes a rationing of health care. And John Kilner spoke to that very eloquently. Thereby, certain populations are at risk, for example, the elderly, the handicapped, the mentally ill, the chronically ill, special needs children, etc. And meanwhile, priority is given to reproductive services, including abortion, school-based clinics, and so on, and a cost-conscious attitude adopted to manage death and dying. Revealing and most instructive is Dr. Kevorkian's rather lucid analysis and projection of the future of medicine described in his book, Prescription Medicide. Let me quote from him. He quote, "Our secularized society has vitiated theistic absolutes. 2, abortion and suicide are gone. Now we must smash the last irrational and most fearsome taboo against planned death." Goes on, "We must eliminate rule ethics, and voila," as Rush says, "the nirvana of planned death, that is positive medicide using his Mercitron device, studying the phenomenon of death while experimenting and achieving organ retrieval of the condemned or the dying, and exercising medical cost control he terms obitiatry, the doctoring of death. Here euthanasia as humane, merciful killing with a positive benefit of scientific experimentation, organ donation, and cost control. Very seductive. Obituaria, across America, there would be facilities in which would be the services provided listed in the current procedure terminology and certain reimbursements be provided. And these obituaries would be proposed to provide death services, which would include abortion, suicide, and euthanasia. He states further that medicine and religion, which is an invented abstraction, by the way, should be completely divorced, and the medical profession must grab its rightful control of ethics, creating the new specialty of bioethics, a new ethical framework for applied science. The rationale, he says, after all, doctors do kill. For example, in abortion and in brain death experimentation and transplantation. In addition, they kill the innocent and gravely ill human being who are comatose. To quote, killing nor homicide per se entail or imply criminal or unethical conduct because it depends on the circumstances. For example, the killer in an execution is the law, and there is no human agency. Likewise, in euthanasia, the killer is the disease or the disorder and not the human agent. He states further, there is no difference in helping a patient commit suicide and actually performing euthanasia. To go on, suicide is no longer a crime in 2/3 of the states. And anyway, the maximum criminal charge is voluntary manslaughter. So, physician-assisted suicide first, and then euthanasia. Kevorkian cleverly notes that assisted suicide and euthanasia are not murder, which is defined as criminal homicide committed with malice aforethought, either expressed or implied and committed recklessly, denoting extreme indifference to the value of human life. So he does not practice murder. Kevorkian continues further, nobody has even a hint of true knowledge about where we came from, where we now are, or where we will go when we die. He describes the Hippocratic tradition as vacuous nostalgia, childish daydreaming, as the profession is rapidly evolving into an integral component of the business world run on boardroom principles. Shadow of Nietzsche. He states that societal evolution requires change. Morality is the present mores of people adapting to change. The philosophy and the ethics follow. The slippery slope argument is dismissed as evidence of a lack of confidence in one's ability to control, an admission of character weakness. Physicians, those simple sentimentalists, should legitimize a control program of planned death, the concept of euthanasia under medical control. Kevorkian perceives himself as a visionary and a futurist. He sees only a positive good in the physician-scientist's unlimited freedom, in fact, a duty to explore without restraint of rule all parameters of the human life cycle: birth, fetology, genetic engineering, life, experimentation, transplantation, death, its definition and the management of dying. What of the future of medicine in this light? The cultural shift is very obvious, as we've discussed the past day and a half. But it's a shift toward moral relativism, the situational ethic, and radical self-autonomy, which governs issues of life, and human relationships. And this will produce, in my opinion, rather severe individual and social pathology. Suicide and euthanasia, along with abortion, really are storming the bastions of traditional medicine, much like the traditional values of sexuality, marriage, and family have been stormed. This does threaten the future of medicine, and as a medical practitioner at the community level for over these 35 years, I view that future with alarm, yet hope. Alarm at the loss of an ethical consensus in the covenantal physician-patient relationship. Our culture, overwhelmed and misguided by the ethos of scientific materialism and utilitarian decision-making, where moral relativism and self-autonomy reign, is, quote, hell-bent on licensing killing as a medical service, so-called medicide. My hope is that this consultation can and will mobilize, in a sense, a reformation or reformation, and come up with some manifesto that will provide the leadership needed to sustain medicine as a true profession, which is a blend of technology and moral commitment to the patient first, the independent advocacy role of the physician. Medicine's fundamental concept of covenant and healing in the context of the sanctity of life remains crucial. Otherwise, the all-too-ready solution to personal as well as social, economic, even political problems is death on demand or perhaps on assignment. Where should medicine go, and where will it go? I feel our goal must be to restore the Hippocratic transcendental covenantal consensus within the profession and within the culture at large, the very character of medicine. I feel that we should disavow the new medicine of technology and skill divorced from values where healthcare is a commodity and medicine becomes agency, representing the community and not the patient. We must reject the context of medicine as power and it's subject to abuse. What action? I would propose that we re-embrace the Hippocratic tradition that precisely prescribes the harm of abortion, suicide, and euthanasia. Though the current context of medicine differs, that vital ethic and its principles remain the same. Medicine future depends upon the moral will and principle persuasion, combined with an uncompromising moral agenda. The physician as healer and not killer. I would close with this notion. Our society's duty is to protect the physician from request to kill.
I think in this context it would be interesting to just present very briefly and quickly the situation in the Netherlands, and then I'll try to draw a few conclusions from that with respect to euthanasia and the future of medicine. First, no, it's the red one. Yeah. First, the definition and also a description of what not should be considered euthanasia. The definition that is given entails the phrase, or the words, request, at his request, by a physician. This means that euthanasia in Holland, by definition, is at the request of the patient. And when there is not a request of the patient, we, at least in general, it's not called euthanasia, but the termination of life. This is in order to make euthanasia more acceptable, I think. It just, personally, I think it's a matter of strategy. In fact, it doesn't matter so much what definition you give as long as you're honest and straightforward and consequent. So in a sense, we can work with the definition. Actions that should not be considered euthanasia, I think that is important in the course of the regulation that we now have and of all the discussions. These actions have to become defined as not being euthanasia. We could talk a long time about them, but we don't have the time to just read it. Stopping or not beginning a treatment at the request of the patient. The patient doesn't want the treatment. Then whatever you find morally of non-treatment, it should not be called euthanasia. B, withholding a treatment that is medically useless or futile. A lot could be said there, and I think when people die because prolongation of life is not pursued because it's considered medically futile, and morally this can be correctly considered so, I think. In the third place, pain and symptom treatment was as a possible side effect a shortening of life. So these things should not be called. So when we talk about euthanasia, we are not talking about any of these actions. Next one, please. However, in the figures, they come back, but as different actions. These are data that arose from a big survey about what physicians did with respect to actions that terminate the life of patients. The numbers are not as important as the pattern, maybe. The requests for euthanasia were 9,000. We have death in the Netherlands from all causes, about 130,000, 50 million people. The request for euthanasia was 9,000, but euthanasia was applied in 2,300 cases. But assisted suicide in 400, life terminated without a request, 1,000. Without a request. Yeah? So there we see that although everybody was saying that we have only euthanasia at request by definition, and we have very strict requirements, and we'll look at them in a minute, in practice it appeared that there were actions that on purpose terminated the life of the patient. And they should be distinguished from those that follow. This is important to realize, because there were actually an intensification of pain and symptom treatment, 3 categories, taking into account the probability that life would be shortened, partly with the purpose of shortening life, and with the explicit purpose of shortening life. Now, intensifying pain treatment with the explicit purpose of shortening life is very, very close indeed to euthanasia, if not the same. So, here again we see that, and now it's interesting, that in the discussion in Parliament, that some members of parliament of the Senate, well, we call it that way too, is the first chamber of our system, that some ask questions about this, and ask whether these actions shouldn't be reported. And it's interesting that the minister said, Minister of Justice, yes, always when there is an action, an act on purpose done to terminate or hasten death, these actions should be reported. But the point is that in all the discussions, this has been left out. And everybody says only 2,300 cases of euthanasia. But now, if it is true what the minister says, and of course it should be like that, then the situation is far more serious than at first they acknowledged. But everybody talked about it then. So there's a lot of confusion in the whole discussion. Now, not starting or stopping a treatment, there we have several categories again. Not starting or stopping at the request of the patient, we have this category that non-euthanasia, 5,800. Without the request of the patient, not starting or stopping a treatment, this without the patient requiring it or asking it. And then here again we have the different categories in taking into account the probability that life would be shortened, partly with the purpose and explicitly with the purpose of shortening life. And you find the different numbers, 14,600, 4,275 and 3,600. Here again, it's very difficult to say what exactly is going on there. Now, stopping futile treatment, we said, is not euthanasia. But if treatment is stopped, and it doesn't say whether it was considered futile or not, but it was with the explicit purpose of terminating the life, again, morally this could be very close or the same as euthanasia. So here again, it's unclear what really the numbers are, but they covered it up. Next, please. This gives you an impression of the size of the problem. Now, reasons or circumstances to ask for euthanasia by patients who ask for it. Fear for pain and discomfort, disfigurement, fear for death without dignity, dependency, being tired and weary of life. Now, these are not medical reasons, at least none of them. And you see here that here we see the model and the ideal of personality, and that ideal is not attainable. Apparently, people begin asking for euthanasia. And whether these asks are really free, I think in practice is very difficult to determine whether a request for euthanasia is really a free request. We could dwell on that, but here again, I just leave it at a statement. Next one, please. These are the reasons for physicians to terminate the life of patients without a request. So the 1,000 patients that I mentioned before, in fact, when you read the report, it's the so-called Remmeling report. Remmeling was the chairman of the commission who made up the report. If you read it and all the figures, I think you could as well conclude that there were 2,000 people who were killed without a request instead of 1,000. But you know, they made estimates on kinds of all sorts of reasoning, because there are 3 different types of investigations, quite complicated. But for the moment, let's keep it at 1,000, but still. The wish of the patient expressed earlier, only 17%. And then you see a number of reasons, of which the no prospect of improvement is the highest. No prospect of improvement apparently then seen as a reason to kill the patient. In a number of, in many cases I should say, the life expectancy of these patients was a week or less, in about half or so, over half I think. So this maybe puts it a little bit into perspective. It's not that these people were well alive and healthy and happy all the time. That's certainly not the case. At the same time, it was on purpose, life was terminated. The next one, please. These are the requirements for careful medical action, as it is called, when performing euthanasia. These are the conditions. If the physician sticks to the conditions, he will not be prosecuted. And if prosecuted for any suspect, he will not be punished. There's the voluntariness of the request. Well, we see that this in practice is not always fulfilled, but nobody knows. So there is no prosecution either. A well-considered request is very much related, of course, with voluntariness. A durable death wish, unacceptable suffering, consultation and reporting. Now, in practice, it appears that, in fact, the quality of life, or the unacceptable suffering, as it is called here, is the reason for physicians to perform euthanasia or terminate the life of a patient without request. And the request appears, and also if you look at the earlier figures, the request makes it easier for the physician and legally more acceptable. But it appears that it is in fact the judgment of the physician and the patient, sometimes together, and sometimes just the physician, of the low quality of life to terminate life. Next one, please. Now, the reporting is important because the whole idea of the regulation we have now is, and let me say this, euthanasia is not legalized in Holland in the sense that it still is forbidden in the penal code. But there is a regulation that when a physician has performed euthanasia, he should fill in a form, and send the form to the coroner, and he will send it to justice, and then justice, the prosecutor, will decide whether there will be prosecution or not. And we have in the law, we have a rule of necessity. You know, the necessity excuse, or what exactly would you call it in the defense of necessity. Thank you, yes, that's the term. The defense of necessity. And that's the reason why the judge may decide not to punish, or now already the prosecutor decides not to prosecute, when he knows that the judge will not punish. That's a defense of necessity, because there is a conflict of duties for the doctor, they say, is to terminate the suffering, and if there's no other way, it can be done by terminating life. Yeah? And that's a defense of necessity. So, but there must be reporting in order to control. The only way for justice to control whether the conditions have been met is by reporting, the doctor reporting his performance of euthanasia. Now, there's a long form with I think about 30 questions that a doctor should fill in with respect to the condition of the patient and the medical condition and the request and other possibilities and so on and so on. But investigation into the question whether physicians were reporting recently under these more or less the same conditions, not really legalized the reporting procedure as it is now, but still among the same conditions, we see that 60 to 75% of the physicians who performed euthanasia falsely and unlawfully certified death by natural causes. They did not say we did perform euthanasia, they just said natural causes, death. Important reason for failing to notify is to avoid administrative fuss. They didn't want not to bother the family with the investigation. Of course, that's not pleasant for the family, certainly not. When justice is coming in, just a member of family died, investigation, questions, certainly not pleasant. At the same time, you know, it's part of the procedure. The reported cases are the well-performed cases. So when a physician has been able to perform all requirements to fulfill the conditions, those are the cases they report, because then just to think, well, it's a good physician, he fulfills the conditions. And in cases when he has not been able to do so much, I exaggerate a little bit to make the point clear, you know. When you look at the figures, it's not all that's white and black, this procedure. But, you know, you can't really get a finger at what really happened, because they reformulate sometimes the report in order to satisfy the legal authorities. So when they write it in a professional way, they describe the situation differently from what they state in the report that goes to justice. So I think this, and now I'm at, this was the last one, isn't it? Oh yeah, one more, yes, okay. The reporting procedure depends completely on the willingness of the physicians to have themselves scrutinized by justice. And these are the numbers of reports of euthanasia that have come in during the years, 1984 to 1993. And the numbers of reports of euthanasia, and you see that it has gone up, and physicians have started reporting euthanasia, knowing that the chance of being prosecuted are very, very low indeed, which you can see the next column, where now it's interesting that in 1993 there were 14 cases, and this was the year that the regulation was accepted. And we see that the Minister of Justice, he is personally opposed to euthanasia, but politically he saw himself forced to make this regulation. And now he has slipped in the condition that the patient should be in the terminal phase, should be almost dying. They didn't really quantify what it is, but kind of dying phase. Not the person who has still months to live. And the 14 cases, 12 of them are patients who were not exactly in the terminal phase. And so the Minister of Justice has told the prosecutors to investigate these conditions. Physicians didn't like it, and they thought it's a trick of the Minister of Justice that he is kind of putting in an extra condition. Because they say, we have been doing euthanasia before the patient was in a terminal situation, and now suddenly it's a new condition. And it can be morally justifiable to perform euthanasia without the patient being in a terminal situation, they say. So there is, struggling going on. But I think 2 points I want to make to finish. First, once you start allowing physicians terminating patients' life, performing euthanasia, even if you try to formulate strict criteria or whatsoever, you lose control. It will be impossible for justice to really know what's going on and to really protect the life of patients as the state should. Whatever regulation you have, I think, because whether a law against or a law that allows it, once the physicians think they can do so, and they may do so, you're lost in this situation. Second, once you're on the slippery slope, the conditions broaden. There's a patient who suddenly was in a very sorrowful situation. She had an unhappy marriage and was divorced. And she had 2 sons. One died of cancer and the second one committed suicide. So, very pitiful circumstances for sure. She wanted to die. And she got into contact with a psychiatrist who had said beforehand that ultimately he was willing to help her in suicide. Now, they had talks and sessions for 3 months, I think. But having said that right at the beginning, the patient didn't want any treatment, any psychiatric treatment, and ultimately she was helped in suicide. And it has been at lower courts, and the physician has been acquitted. But this suffering did not have a medical background. It was real suffering, without any doubt. But it did not have a medical background. So if this is accepted, the physicians can be made responsible and apparently feel themselves authorized to terminate whatever suffering a person may experience. And then coming back just for this statement to my former statement, I think then we see that the physician is the one who is more or less responsible for the happiness of the people, in a sense. And I think that's a totally new medicine.